move on and talk about how to interpret. I'll go over palpitations briefly and then some 24-hour ECGs. And then if we've got time, we'll go on to exercise tests. So, palpitations. How do you assess somebody who complains to you about having palpitations? So, the first thing you want is to get the patient to describe the palpitations to you. And what sort of questions do you ask? So what are the key descriptions? Shortness of breath, dizziness. Yeah, we can certainly ask those questions, but I would constant or come and goes. Yeah. So you would start off by wanting to know, yes, excellent. So thank you, Jacob. Frequency, length of time, and associated symptoms, pain, breathlessness, lightheadedness. It'd be pretty unusual to get pain with palpitations. If you're having an anxiety attack, that's very often associated with chest tightness. Angina would rarely be associated with palpitations. It wouldn't usually be a dominant feature. If you have fast atrial fibrillation and ischemia caused by the fast atrial fibrillation, I could see how that might cause chest pain. So it's all things are possible, but relatively unlikely. But breathlessness and lightheadedness are good and useful symptoms to ask. So we want to know things like how long they've been happening, how often they happen, how long they last for when they happen. Can you break it down into a bit more detail than that? So these are fairly superficial questions or things that we've asked so far. Anything that you can use to nail it down a little bit more? Because pretty much any cause of palpitations might have been there for half an hour, coming and going once a week. It's obviously important to know if they've had them since childhood and they're 90 years old, you might have to relax a bit more about them. So precipitating factors, yeah. So what precipitating factor would you crucially be asking about? So exercise is a really important one. Thank you. You just got there after me, but I'm sure you were typing that before I said it. So exercise causing palpitations is a real red flag. Normally, palpitations are suppressed by exercise. Sometimes patients go into fast atrial fibrillation on exercise, but exercise-induced palpitations make you worry about ventricular tachycardia or risk of more serious arrhythmias. So that's a key question to ask. Um, the other sorts of questions I want you to be asking are things like the onset and offset of the palpitations. Things like how long do the individual palpitations last for? So if a patient is having ventricular or atrial ectopy, they tend to describe that they'll be sitting quietly watching TV and their heart suddenly does a somersault in their chest, or they're sitting quietly watching TV and suddenly their heart stops. And then there's a great thump as their heart starts again, and they keep on thinking it's going to stop and not restart. Often they can have that episode multiple times in quick succession over half-hour period, but sometimes it is just single isolated episodes. So that sort of description of a somersault or the heart pausing and suddenly restarting, that sounds like a ventricular ectopic beat because the heart doesn't contract efficiently during the ventricular ectopic. Partly it's not had time to fill fully, partly it's an disorganized relatively electrical activation of the heart. So the ventricle ends up much more full by the time it's had the compensatory pause after the ectopic, and then it pumps harder and they feel the sort of sudden pound in their chest. The onset offset is very useful with tachycardias or with sudden with longer episodes of palpitations as opposed to the single sort of jumpy beats. If a patient complains of fast palpitations which come on suddenly, that is just a fairly typical thing, no matter the cause of the palpitations. So even anxiety attacks, where if you look on a 12-lead ECG, a 24-hour ECG, you can see the heart gradually accelerating over a minute or so. The patient still feels that they tend to come on suddenly because they get spooked by something, the adrenaline surges, and the heart rate increases. So onset is typically sudden with palpitations. But offset, if that is a sudden offset, that can be very helpful because that would suggest a pathological cause. So atrial fibrillation can seem to go away gradually, but if it's a supraventricular tachycardia caused by something like an AVNRT or an AVRT, Wolff-Parkinson-White, that tends to have a sudden offset. So that's a useful symptom. Gradual offset is, generally speaking, reassuring. We've talked already about exertion and other provoking factors. Coughing or alcohol are important things to think about. Assessing the rate can be of value because patients, it's very hard often for them to describe palpitations in detail. But if you tap it out for them, that can help it to crystallize for them. And so you can ask them, is it a pounding regular beat at a normal rate? Or you can say, is it fast and irregular? And they can then say, no, it's not as fast as that, or it's faster than that, or they can say, actually, it's regular. And it can help them to understand it. And obviously, if it's fast and irregular, it's pointing you towards atrial fibrillation. If it's slower pounding, then it's more likely just the heart doing a normal thing and then becoming aware of it. And so thinking that it's a palpitation when there's no underlying pathology. Remember, palpitation just means awareness of heartbeat. It doesn't necessarily mean pathological. Everybody gets palpitations when they exercise, for example. And associated symptoms of, does it cause them to be pre-syncopal or even cause syncope? It's relatively rare for palpitations to cause syncope. Typically, heart arrhythmias that cause syncope present with the syncope rather than with the palpitations, but it's possible, and syncope is certainly a red flag. Remember, syncope being sudden loss of consciousness, suggestive of brady or tachyarrhythmia. It's not feeling warm and lightheaded and having a prolonged period of pre-syncope leading to syncope. Even that associated with palpitations would give me concern. But obviously, if they don't have palpitations, but they have a long episode of pre-syncope followed by syncope, that makes you think vasovagal. Great. We also would like to know other details. So I think that covers the history of palpitations, but we also want other details. So what other questions would you ask the patient about? Yeah, past medical history and family history, and anything specific, because patients are very good at forgetting to tell you the real crucial factor. So anything more specific than just general family history and past medical history. And we certainly want to know about alcohol. That's good. So alcohol, nicotine, caffeine, and other drugs. If they're regularly snorting cocaine, then that will quite nicely cause palpitations. Alcohol, very often patients get atrial fibrillation caused by alcohol, but it will also cause ventricular ectopy or even ventricular tachycardia. Often patients get palpitations when they're hungover the next day. So alcohol is actually very poorly understood, considering how much of it is consumed. It's very poorly understood exactly what normal and abnormal arrhythmias you get with it. So I want you to be asking about cardiac past medical history. So have they had a ischemic heart disease, infarct, some form of structural heart disease is the key. The other thing, family history, make sure you ask about sudden cardiac death and ask, has anybody died suddenly at a young age? Don't just ask family history. And then the key examination features of listening for a heart murmur, assessing blood pressure and pulse. And there are red flags that I want you to remember in all this. So the red flags are if the palpitations are worse with exercise, that is a big concern for us. If they have syncope with it, that's a very big concern indeed. That should lead to hospital admission to find out what's going on. If they have a family history of sudden cardiac death, that again, I'd be thinking about an admission to get to the bottom of it. Structural heart disease, so it could be atrial fibrillation in somebody with structural heart disease, but we do worry about ventricular tachycardia, so that would be a big red flag. And also we obviously want to do their ECG and look for any abnormalities. There are lots of different possible causes of palpitations, and this is not supposed to be an exhaustive list, but it covers some of the main ones that we're going to look for. So the most common cause of palpitations is sinus rhythm or sinus tachycardia if the heart rate is fast. And that could be anxiety or hyperthyroidism, or very rarely a pheochromocytoma. I live in hope that I'll one day be the first person to make a diagnosis of that. I've done an awful lot of 24-hour urine collections. But loads of other things that can cause sinus tachycardia and symptoms of palpitations. The other very, very common thing is ventricular and atrial premature beats. So very, very common cause of palpitations, and by and large, they are pretty benign. Some patients, every other beat is a ventricular ectopic beat, and that starts to become concerning. But those patients don't tend to complain of palpitations, because if they did, they'd complain long before it became as frequent as that. Atrial fibrillation, flutter, atrial tachycardia, we've talked about those in a separate presentation. Those are obviously very common and very important to look out for, because we need to anticoagulate these patients if appropriate. And then AV nodal reentry tachycardias or atrioventricular reentry tachycardia. We talked about those the other week when we talked about tachyarrhythmias. So these are abnormal electrical wiring in the heart, allowing fast palpitations to start up, that patients might self-terminate by doing a Valsalva maneuver or rubbing on their neck, or coughing, for example, splashing cold water on their face. So those we need to spot, because there's a cure that we can offer patients for that, or we could suppress them with medications often quite nicely. And most seriously of all, ventricular tachycardias, which are mercifully very rare in patients who don't have abnormal hearts. What investigations should we think about doing? Well, I'd do a 12-lead ECG in pretty much all patients presenting with palpitations. I would not necessarily do anything further if I'm satisfied from the history that it's nothing to be concerned about. But if I was worried, I might do an echocardiogram or cardiac monitor or an exercise test. So moving on now to types of cardiac monitoring and how to interpret cardiac monitoring. The typical type that we do is a 24-hour ECG, and that's got 3 electrodes and a little box that the patient wears for 24 or 48 hours and then brings it back to us for analysis. There are other forms that you might come across. We don't tend to use these in the NHS, but they might be available privately. So little sleek monitors which you can just stick on. And we can apply monitors like this, or like the first option, for about a month if we want to. But if we think the symptoms are less frequent than that, and so we're not going to be able to pick them up with a decent period of monitoring, we can put an injectable loop recorder in called a Reveal Link now. This is the main one that we use. There used to be bigger things. Look at this for marketing. This is a Medtronic marketing thing, and you can see this is actually smaller in length than this device, but they've made it look bigger here in their picture. But this is a reveal link device, and it is about the size that it probably appears on your screen. It's nice and, in fact, smaller than that. It is genuinely injectable and takes 5 minutes to put in. Can be quite hard to find, to take it out afterwards. Battery lasts for about 3 years, and it's very good at detecting if there's an arrhythmia, but we crucially want the patients to complete a diary so that you can look at when they get their palpitations, at what their heart's rhythm's doing, because actually knowing their heart rhythm is normal when they've got their symptoms is extremely helpful, or knowing that what you're not sure if you need to do something about or not, if it's a 3-second pause, is that causing their symptoms or not? Probably not is the answer, but correlating that with their symptoms is really valuable. So why do we use 24-hour ECGs? It's in order to diagnose arrhythmias. It's to assess the severity of symptoms. So we might have diagnosed ventricular ectopics, but the patient might be terribly symptomatic, and we do a 24-hour heart monitor. We might find that there are only half a dozen on a 24-hour tape, or we might find that there are several thousand. We want to assess the severity of the symptoms and the severity of the arrhythmia. We also might want to see, have those ventricular ectopics settled down. If in a symptomatic patient, they'll often tell you. So is there really any point in checking up on what the patient's told you? Not really, to be honest. But there are patients out there who have 25, even 50% of the time, they're having extra beats. So when the heart's having extra beats as often as that, it can lead to inefficient function of the heart. And so we can really want to suppress the extra beats in order to prevent development of heart failure. So we could repeat the monitor to assess that. You might also want to see if you've been effective in resolving atrial fibrillation, for example, although again, that's of relatively little value. It's actually really to see suppression of excess burden of ventricular ectopy that's most useful. And autonomic function is hard to assess, but one of the ways to assess it is a 24-hour ECG. I wouldn't recommend that as in clinical practice, but if you develop an interest in that or you want to do research, 24-hour ECGs can be very useful to assess that. So can anybody tell me what's a normal feature of a 24-hour ECG? So tell me something that's a little bit abnormal on a 12-lead ECG, but you might let pass on a 24-hour ECG. And I'll put 1 or 2 suggestions out there. And the answer to the question I've just asked, which I hope you're all trying to answer, is that actually we don't really know. And that's because we haven't really done large-scale studies of normal people and done 24-hour ECGs to see how often they might have a 3-second pause, for example. We do know that young patients often develop Venky-Bach during the night because they have high vagal tone during the night. We do know that young people often have heart rates down to about 30 overnight, but we don't know if we don't know for sure lots of different things about whether or not things are normal, abnormal. And it's not just to do a study in a group of normal young people. What about in 80-year-olds? And if you did a trial like that, you'd probably pick up a load of incidental things. I mean, if you find a few second run of atrial fibrillation in a 90-year-old, are you going to anticoagulate that patient? Is it going to help them? So we have to be very judicious about doing a 24-hour ECG because we will struggle sometimes to know what we can ignore and what we need to do something about. It is easier to say what abnormal is, thankfully. And the first thing to say about that is consider the patient. So consider what might be normal for a 30-year-old and what might be normal for a 90-year-old. And absolutely critical is to look at the symptom diary. We need to match up the symptoms with the heart rhythm. We would say that having 3 or more beats of ventricular ectopy together in a row, I'll show you exactly what I mean by that in a minute, but 3 or more beats is abnormal. So non-sustained, as soon as you have 3 ventricular ectopic beats together, that's non-sustained VT. It's still non-sustained VT if that episode lasts less than 30 seconds. So you could have 59 beats at a rate of 200 of ventricular ectopy one after the other, and you'd call it non-sustained VT, as opposed to ventricular tachycardia if you had 60 beats and it therefore lasted 30 seconds. So it's a very broad definition. 3 beats of non-sustained VT, probably we don't need to worry too much about if our heart is structurally normal, although we'd feel a bit queasy about it. We wouldn't really know what to do about it. But that's certainly, we're looking out for that in our 24-hour ECG. Heart block, so 2 to 1 or higher heart block, doesn't matter how asymptomatic the patient is, doesn't matter if it's happening at night. That's a sign that there's a break between the top and the bottom chambers. Venky-Bach, note that's different. So gradual prolonging of the PR interval followed by a non-conducted P wave. Venky-Bach is fine, particularly in young patients. If you've got an elderly patient, that's more of concern because they shouldn't have such high vagal tone. And if it's happening during the day, that's also of concern. But nocturnal in a young person is fine. But 2 to 1 heart block or complete heart block is a big concern. And we would say that 3 or more second pauses during the day are abnormal, and at night 5 or more second pauses are abnormal. And the other thing to always look out for is atrial fibrillation. So you may find it incidentally. So atrial fibrillation lasting for more than 30 seconds, we'd need to think about anticoagulation. Let's move on to a patient. So imagine we have a customer who is complaining to us of palpitations, and we've done a 24-hour ECG. So you get this as your front page of your report, and this is quite useful. And please try your best to ignore what it says in the comments section and come back to that after you've had some chance to assess it yourself, because you really benefit to you to do some thinking. And if something's missed that's present on the 24-hour ECG that you look through, it's still your fault for missing it. You can't, the technicians have done their best, but you need to do your job as a doctor too. So useful things to look out for on the tape are when it was done, how long was recorded. So you're expecting that to say roughly 24 hours, as opposed to might have only been on for a few hours. Sometimes patients take them off halfway through. You're not really caring so much about the number of beats there are, but you do want to look over here at the number of aberrant beats. So this is the number of ectopic beats, and that's 18 here, which is a pretty normal number. You'd expect there to be at least half a dozen ventricular ectopic beats in a 24-hour period. 0 is nothing wrong with 0, but you expect there to be a few. That's normal for there to be a few. You might glance a little bit at these bits here. If they're bradycardias, drop beats and pauses, you need to look at those in more detail. And that's about it for the front page. I don't spend any time looking over here at this bit. The bit I want to then move on to is page 2, and not this bit of page 2, which just don't worry about. This is the bit I want you to look at, and this is the most useful bit of a 24-hour ECG. This is the heart rate over a 24-hour period. So you have time along the x-axis and heart rate along the y-axis. So you can immediately see here that the heart rate varies between a bottom rate of around 40, which it obviously does tell you there, and a top rate of about 89. And you can see that it goes up and down. And that's normal autonomic function. You can see that it dips during the night. Again, that's what we expect. That would be normal autonomic function. You can see the sudden increase in heart rate as the patient wakes up. Okay. And we can see that the mean heart rate is about 60. So this is all looking very normal. We then can have a look at the ECGs that have been recorded. And the crucial thing that we need to see are the patient events, if there are any. And so here, can you see that the heart's P wave, QRS, P wave, QRS, P wave, QRS, and then this broad ventricular ectopic beat comes in, followed by a second one. So this we'd call a couplet. This is two ventricular ectopic beats, one after another. A triplet would be another one of those, and that would then become non-sustained VT that we've just been talking about. The fact that this is associated with symptoms is going to be because these two beats will not have been efficient activation of the ventricle. They've come early before the ventricles really had time to fill. But after an ectopic beat, you get a compensatory pause. So the distance between those two RR intervals is great. And that means that the ventricle is much more full of blood. It means it pumps much harder. And that's the somersault that patients often describe. That's the thump as the heart kicks back in and the patient says, thank goodness my heart started again. And these you can be very reassuring about. We don't like the fact that there are two occurring together, but providing the patient's heart is structurally normal, they've got no family history of note, their 12-lead ECG is normal, I wouldn't do anything further about it. We could offer a little bit of beta blocker to try and suppress the palpitations, but it really comes down to the patient. Often reassurance is all they need to be satisfied that they often I tell patients that they've got themselves quite tuned into listening to their heart, and most people are completely unaware of this happening, and makes them feel a bit special, and it satisfies them that they know what's going on, and that often is what they need to settle down their symptoms. Remember how debilitating it can be being worried that your heart is abnormal. That reassurance is really important for patients, and obviously the symptom diary is really helpful. Now, what do you think of this example? So I've just shown you something which I said was a very normal sort of appearance. Does anybody have any comments to make about this example? Again, this is the heart rate over a 24-hour period. This is how the heart rate is varying. So the maximum rate's a bit high. Thanks, Jacob. Well, yes, it is. Rate of 120. That is a bit high, but it's not, that's not that high. Your heart rate probably exceeds 120 at some point during each day. I hope it does, because you hope you do some regular exercise. So depending upon the patient, you might say that, this 90-year-old has got quite a fast heart rate at some times, but it's not really of concern how fast it's going. Anybody else want to make a comment? Yeah, there are multiple episodes of heart rate around 60. So this is a heart rate of 60. So it spends quite a lot of time during the night at a heart rate of 60. Yeah, I think that's fair. So there are quite a lot of episodes with a slower heart rate. Can you see how stepwise this ECG looks? So you've got a relatively fast bit here, and then sudden step down, slower bit, sudden step up, faster bit, sudden step down, sudden step up. See how this is a tale of two rhythms. And this immediately should make you think, I need to see what the heart is doing during this bit. I need to see what the heart's doing during this bit. And so we then go into the main part of the 24-hour ECG. And can you see here that this is atrial fibrillation, rate going about 120. And this is sinus rhythm. And I don't want to labor this too much, but can you see how this T wave looks different from this T wave? That's because this T wave has got a P wave in it. And that is going to be an atrial ectopic, which is arriving probably early to the point that it's not followed by a QRS because it's too early to capture the ventricle. So this is frequent atrial ectopy at night causing this relative bradycardia. And this is not a reason to be concerned in this patient. If you had a longer pause, it would be, or if you had signs of 2-to-1 heart block, it would be, but this is okay. But the fact that they've got some fast atrial fibrillation rate of 120 and they've got some bradycardias, we're going to have a job controlling the faster rates without making these slower rates go down too much. So what we do here has to depend very much on the patient's symptoms. If the patient is symptomatic, then we would have to think about slowing them down with a bit of beta blocker, and that's likely to wind up with the patient needing a pacemaker. If they're not particularly symptomatic, they're just aware of palpitations, then you can reassure them that they've got atrial fibrillation happening intermittently, and that's why they've got palpitations, and that they don't need to worry about the rate control of it. If they were symptomatic from it and it's this atrial fibrillation, we could try to do an air fibrillation so that they stay in the sinus rhythm all the time, but that would only be in candidates for that. And that's a symptomatic treatment rather than something that's necessary. What is crucial here is that we remember to consider anticoagulation for them. What about this ECG, this 24-hour heart monitor? Can anybody tell me what this shows? So I imagine that you're all falling over each other to write runs of SVT. So what do you mean by runs of SVT? Do you think this is supraventricular in origin? Or do you think this might be ventricular in origin? So we've got an underlying broad QRS. And then we have a different morphology tachycardia. And that makes it exceedingly likely that this is VT. We can't know for absolutely 100% because all sorts of things are always possible, but we should be worried about a VT here. Now, is this sustained or non-sustained VT? So if you remember, I said that 1, 2, 3 beats make it VT. The next question is it sustained or non-sustained? And we need it to last for 30 seconds for it to be sustained VT. This run here is maybe 15 seconds. So this is non-sustained VT. So this is non-sustained VT, and just 3 beats of it would also be non-sustained VT, but this is much more concerning than just 3 beats of it. This one here, we're only seeing the end, so maybe this has been going for 10 minutes before it reaches an end. We don't know. So we don't know for sure if this is non-sustained or sustained, but we're imagining it is non-sustained, otherwise they would have shown us that one. So this patient has non-sustained VT, and this patient has got a broad QRS underlying this. This is the kind of thing we need to be thinking about hospital admission for this patient. And we need to suppress this with medications. So If you see this on a 24-hour ECG, it's worth phoning up the patient and finding out what their symptoms are if you don't know already. But this one requires further treatment. This is what VT looks like on a 24-hour ECG. This example, can you see how, again, there seem to be two different heart rhythms or heart rates here? And this is the sort of patient who will really struggle to rate control these episodes while also controlling these episodes. So we could try a little bit of beta blocker, but pacemakers for tachycardia syndrome, for fast and slow heart rhythms, are a very common reason to put a pacemaker in. So this patient may well end up needing one. Imagine you're on the ward. Imagine you're on the ward at the weekend and the nurse comes to you very concerned at about 9 o'clock when you first come on shift and says they're very worried about this patient. Half an hour ago they started doing this. Could you come and have a look at them? What do you think of this cardiac monitor? Yeah, it looks like Torsade de Pointes, doesn't it? It possibly looks like VF. You can see the sort of rhythm sort of looks as if it might be corkscrewing round. Is everybody satisfied? It's probably one of those two rhythms. Have a look at the third lead down. And remember, these are recorded simultaneously. So if you can see a QRS in lead 3, it's happening at the same time in these leads. It's just you can't see it. And can you see how there are R waves distinguishable within this noisy band? So this is just noise, and the patient might have been brushing their teeth. This is in fact an underlying atrial fibrillation, which is probably a little bit tachycardic. So think about anticoagulation, but you can reassure everyone that this is not an arrhythmia. Obviously, you might want to go and see the patient and make sure that they're well. Good. So that's what I wanted to say about heart monitoring. This is an example of a superb piece of research that was done back in 1998 using the 12-lead ECG. So just if you want to do some research and you need some ideas, this is the sort of thing that you can spend 3 years of your life doing. So let's talk about exercise tests in our remaining quarter of an hour or so. Exercise tests have gone out of fashion, and I do think that's a shame because they are really useful tests. But it's more expensive to do a CT scan, but it's much more fashionable to do that, and that's what we're doing these days as a first line, according to NICE, and finding lots of incidental omas along the way. Exercise tests are done to look for ischemic heart disease, and not all comers can do an exercise test, which is a definite limitation, but presence or ability to do an exercise test or not is actually a really important prognostic marker. Exercise tests can also be done to try and provoke arrhythmias. So if you have a patient with palpitations you're worried might be exacerbated by exercise, it might be worth doing it in a controlled manner, bearing in mind that causing somebody to go into VT when they're exercising hard is intrinsically not a very safe thing. So we need to watch over these patients carefully. And to some extent, you could also do it to assess symptoms. So let's have a quick example of an exercise test. Imagine we have a 55-year-old woman who's overweight. You might immediately tell me that women, their exercise tests are not as discriminatory as men's, and that's absolutely true. If she's postmenopausal, then this becomes useful again, but premenopausal women do tend to get ST depression as a normal finding on their 24-hour their exercise tests, so it's not so helpful. But this lady's overweight and diet-controlled diabetes. She's got breathlessness and exertional chest tightness, so she does an exercise test. And you get lots of useful information on the first page. So you can see that their maximum heart rate should be 165, and 85% of the maximum therefore is 140. This is just 210 minus the age. And we can see what heart rate the patient achieved. So here they got up to 156, which is well over the 85% of maximum. So this is a sufficient amount of exercise to make a diagnosis. You can also see, look how fast the heart rate went up. And look how short the exercise duration was, just 4 minutes, 8 seconds. So this tells you that the patient is really rather unfit and that their heart rate zips up really fast when they start to exercise. Their blood pressure shoots up appropriately and then it comes down appropriately afterwards. If we look at the traces, this is the trace at rest, and that looks fairly normal. And this is the trace as they exercise, and this is at peak exercise just before they stopped. And can you see that there's a little bit of upsloping ST depression here? And that actually, I would say, is pretty normal. Although the fact that she complained of central chest discomfort does give you some concern, because the presence of pain is potentially points towards angina, but very often this is just tightness because they're puffing hard. So I would say this is probably a negative exercise test, but it can be a little bit hard, and a very experienced colleague thought that this might be ischemic. Of course, it turned out not to be, but you have to be safe. And this is partly why exercise tests are out of fashion. It's because this lady has only managed a fairly short period of exercise. That's told us she's very unfit, and we need to talk to her about the importance of exercise. So lots of useful information, but it creates some uncertainty, and these ST changes have created some uncertainty. So it's about 80% sensitive, about 70% specific for detecting coronary artery disease. And we get patients to do something called the Bruce protocol, the full Bruce protocol, which technically is 7 stages, but we only do the first 4. I don't think many of you could get to stage 7. I certainly couldn't. Each stage lasts about 3 minutes. They start off walking at about 1.7 miles per hour up a 10% incline. So the 10% incline is actually quite steep, but it's quite a slow walk. And this energy expenditure is estimated to be about 4.8 metabolic equivalents. I'll tell you more about that in 1 second. And each stage they go through, it gets steeper and faster. And if somebody's not going to manage the full Bruce protocol because they're not fit enough, we can do a much gentler one called the modified Bruce, which I wouldn't generally recommend. So I just mentioned that stage 1 is 4.8. We'd estimate just daily living activities use about 5 mets. If you're sitting resting, you're using about 1 met, which is that's about 3.5 milliliters of oxygen per kilo per minute at rest. So it's a fairly low amount of exercise, stage 1. How do we prepare the patients? We can stop medications. Digoxin we probably do need to stop because you can get the reverse tick effect I showed you in the ECG at the beginning, and so it can be very hard to predict. But of course, if you do this and they're in atrial fibrillation, their heart rate may be uncontrolled. So I probably would carry on beta blockers in somebody with AF, and if they had to stay on their digoxin, I'd probably not do the test because it won't be helpful. Other medications we can probably leave on. We talked about maximum predicted heart rate. Let's move on to another example, this time of a 50-year-old man who's a smoker with a week of exercise, of exertional chest tightness. So this time round, he's managed 3 minutes, 23 seconds. His heart rate hasn't gone up by as much, hasn't reached the 130. So he hasn't achieved as much exercise, as much heart rate as we would have expected him to. His resting ECG looks fairly normal. This is at the start of exercise. At 2 minutes, 52 seconds of exercise, can you see any abnormalities there? So if you look in V4, this is slightly upsloping, but I would put it to you that's fairly horizontal ST depression of about 2 or 3 millimeters. And he's also got it in V3, a little bit in lead 2. Now, you can't localize where the ischemia is on an exercise test. You tend to get depression in leads regardless of the location of the ischemia, but this is a strongly positive exercise test. And we then stop them. Here, can you see this is horizontal. And fairly rapidly, the appearances resolve. So this is 1 minute into recovery. This is 7 minutes into recovery. The ECG's gone back to normal again. So that's a strongly positive exercise test. In stage 1, that patient needs a coronary angiogram and their heart looking at. And we know that from a study called the Courage trial. So it's an example of a really useful exercise test. Why wouldn't we want to do an exercise test? Well, lots and lots of really, really obvious things. So very high blood pressure, severe aortic stenosis, unless we're doing it specifically to assess the aortic stenosis. Basically bad things. You're not going to do an exercise test in someone with a dissecting aneurysm, for example. We also need to bear in mind that there are false positives and there are other things that can cause ST depression. That patients can be too frail to do an exercise test. And if they've got an abnormal resting ECG, it's often very hard to interpret the exercise test. The other thing is that you can cause myocardial infarction or arrhythmias with an exercise test. This is an example of a 65-year-old man who had a previous anterior MI who came in with chest pain but a negative troponin, and we didn't think it was likely that he had ischemia. This is some years back, and we did an exercise test, his resting ECG. Can you see that there are anterior Q waves? And as he exercises, can you see that there's some ST elevation here? Go back. Can you see how these QRSs, these segments go up slightly? It's very hard to know what to make of that in leads with Q waves in them. We can see here that there's probably a little bit of upsloping ST depression. Probably that's okay. Not really sure what to make of this at 6 minutes. As we carry on, can you see now these segments are definitely going up? There is definitely ST elevation here. And then they go into an arrhythmia. So this patient, thankfully, was cardioverted quite nicely, and he ended up with some more stents. Whether or not he really needed them, given that he didn't really develop symptoms until after stage 6, it could well have been non-cardiac chest pain that brought him in, but certainly the exercise test wasn't particularly useful here, and we don't tend to use them like that anymore. But that's an example of why you have to just be aware of the risks of doing an exercise test. We don't formally consent patients for them. The normal ECG with exercise is initially, you might get some slight increases in size of the P wave and the QRS. You often get this J-point depression and upsloping ST depression. That's a normal finding, like in the first case that I showed you. Reasons to stop. If you've got more than 3 millimeters of ST depression or any ST elevation in a non-Q wave lead, any ST elevation, you need to look out for and immediately stop. If you're getting increasing frequency of ventricular ectopy, that would be a concern. They should be suppressed. Ventricular ectopics should be suppressed with exercise rather than increase, unless you're specifically doing it to assess for ventricular arrhythmias, in which case get ready for some excitement. If they have VT, please stop. You know that. atrial fibrillation or supraventricular tachycardias, if they develop during the test, that's probably a reason to stop. New bundle branch block might be a sign of ischemia, makes it very hard to interpret, so I would stop at that point, and certainly if there's heart block or cardiac arrest. So fairly obvious reasons. The one that you need to really look out for is ST elevation, because you can easily miss that during an exercise test. And also, if the patient requests it, or they're getting severe chest pain, or their blood pressure's dropping, or they're too hypertensive, then stop. These are the criteria we use. I did try to look up before I asked our team what they did, and I found this paper, which is from the European Heart Journal, a very respected journal from 2005. And it said the test was stopped for safety reasons if a blood pressure of 300 millimeters of mercury was reached, because the top of the mercury scale of the sphygmomanometer was 300 millimeters of mercury, which I found quite amusing, which is why I shared it. But we use a non-official value of 230 systolic or 115 diastolic. Remember to record for 15 minutes after, or at least 5 minutes after the exercise test, for up to 15 minutes, looking for ST segment changes, which are as significant as those that occurred during exercise. Wonderful. So that's everything I wanted to discuss. I know we don't do that many exercise tests anymore. We do, relatively speaking, do more as a unit than many places. And I do think that they still have a good role, particularly in young patients who are fit and able to exercise. They can be a really good way of avoiding lots of X-rays in ruling out ischemic heart disease. But NICE disagrees, and perhaps you should listen to NICE rather than me. Next week, we're going to talk about echocardiograms. Do we have any questions?